Hello, everyone, and welcome to the Florida HIE Services webinar on the Encounter Notification Service for
FQHCs.
On behalf of Florida HIE Services, I'd like to thank everyone calling in or watching the webinar today for joining us. Today's webinar will feature a question and answer format with individuals who represent the policy as well as the technical side of the service, as well as a representative from a community health center. My name is Chris Wilkie, and I am the Health IT Outreach Specialist for the Florida HIE. Before I introduce today's guest, I would like to tell you a little bit about the Florida HIE itself. Florida HIE was founded in 2011 and has been facilitating the secure exchange of health information through several services between healthcare providers, hospital systems, and payers. Florida HIE Services offers three services: the direct messaging service, which is a secure HIPAA-compliant email service that is also Direct Trust accredited. We offer the Query Solutions, which offers a way to query clinical documentation for a specific patient across the eHealth Exchange and Care Quality through the State Gateway. Lastly, and the reason we're here today, is the Encounter Notification Service. The Encounter Notification Service offers real-time hospital encounter notifications, and these include admissions and discharges for inpatient and emergency department visits. The Agency for Healthcare Administration governs the Florida HIE by setting policy, convening stakeholders, providing oversight, and engaging our federal partners. The technical side of Florida HIE is provided by Audacious Inquiry. They contribute innovative technology and strategic insight, as well as management of the day-to-day operations of the Florida HIE. Before we begin, I just want to let everyone know who's joining today that we will have time at the end for you to ask some questions. You can do that one of two ways, either by raising your hand on the control panel or just by manually typing them in, and we will field all those at the end of the presentation. Also, the slides for today's presentation will be sent out via email after the webinar, as well as a recording of the webinar. All right, so let's get into our two guests for today. Our first guest is Aaron Parsons, Manager at Audacious Inquiry. Aaron, can you tell us a little bit about yourself and your role with ENS at AI?
Yeah, happy to do so. Thanks for the intro, Chris, and for to you and to Aka for hosting the webinar. We're really excited to be talking about this morning. My name is Aaron Parsons. I am, as the slide says, a manager at Audacious Inquiry. I've been involved with a variety of health information technology projects in Florida since 2011. I worked on the Medicaid EHR incentive program, direct e-prescribing, and been working for the last few years on the Encounter Notification Service, which we'll get into a lot more detail a little bit later this morning. So thanks again for the invite and introduction.
Sure thing. Thanks, Aaron. Also joining us today is another special guest, Sherry DeCuba, Chief Information and Compliance Officer at Treasure Coast Community Health. Good morning, Sherry.
Good morning.
Would you mind telling us a little bit about yourself as well and your role at Treasure Coast Community Health?
Certainly. So as you said, I'm the Chief Information and Compliance Officer. I've been with Treasure Coast Community Health almost 10 years and take care of FQHCs. We take care of just about everything. I work with our EHR system is one of my roles as well.
Awesome. We're happy to have you this morning. Thanks for joining us, Sherry. All right. And with that, I'd like to go ahead and field our first question. Aaron, as far as working with AI and being on the technical side, I want to ask you if you could just explain what ENS is.
Sure. That sounds like a great place to start, right? So ENS, or the Encounter Notification Service, is a service that is available through the Florida HIE, and it provides an alert anytime a patient receives care at a participating hospital in Florida. We have really great hospital participation, over 215 connected acute care hospitals that together cover 95% of acute care hospital beds. And all these hospitals are connected and sending us data in real time. And that includes inpatient and emergency department encounters and admissions and discharges. And so we receive all this data in real time, and then we are routing that out to covered entities like FQHCs that have patient consent so that they can use the data to assist with the transition from the hospital to from acute to post-acute care, or from acute to home as the patient is discharged. You can, as the slide mentions here on that last bullet, you can see the complete list of participating hospitals. If you want to know what hospitals in your area are connected, if you go to our website, which is florida-hie.com or .net.com, I think redirects to the .net site, you can see under the participants tab, there's a really great interactive map, or if you prefer just to have a list, you can download an Excel spreadsheet. So it's totally transparent. You can see everyone who's connected and find out whether the hospitals that you work with and that your patients often go to are connected to the network. And if they are, then you'd be able to receive data on their encounters via ENS. So that's a very high-level summary of the service. We're routing hospital encounter data in real time out to doctors to assist with patient care.
Yeah, that's a great introductory explanation. Let's get into a little more detail with, would you mind talking about how the service actually works?
Sure. So for a covered entity or provider or FQHC that we're interested in subscribing, say, hey, it would be really useful to know when our patients go to the hospital. ENS is the platform that enables that, and you're able to receive that data by sending us a list of your patients that you want to receive alerts on. So of course there's an agreement and some prep work we need to do. But the thing that drives the service is this list of patients that you would provide to us. And that list includes some basic demographic information about the patient. So their first and last name, their date of birth, address, phone number, insurance number, information like that. So we use that information to compare against the data that we have coming into us real time from our connected hospitals. So we get the lists from the FQHC. We have all this in live data coming to us from the hospitals, and we're comparing these two sources of data. And so it's great in that the service doesn't rely on the patient to successfully attribute themselves to a particular payer or ACO or FQHC. Instead, what we're relying on to route the data is the demographic information that's provided both by the hospital and by the subscriber. And I'll just say FQHC going forward, since that's our audience today. So we're looking at first name, last name, date of birth, social, gender, address, phone number, insurance ID, and other pieces of demographic information. And we're attempting to match those across all of those different data elements. And if we match on enough of them, that we can be certain with a very high degree of certainty that patient A at the hospital is in fact the same patient A that is on this FQHC list of patients, when we are certain that it's the same patient, then we will go ahead and consider that a match and route that data out to the subscribing FQHC. And whether we have a match or not, we purge the data from the system. So after we attempt the match, so we're not holding any of this data. So we don't have a warehouse or anything like that. We get the data from the hospitals, we attempt to match it to the subscriber list, and then we go ahead and route it out. How we route it out, and I imagine we'll get into that a little bit more during this call, is really entirely up to the connected subscriber, the connected FQHC. So we have a bunch of different options around how, when, and where the alerts are delivered. And so we'll work with you as you're getting hooked up to set that up according to your preferences. So most folks want a batch delivery twice a day because that works better with their staffing model and kind of their existing business processes. But we can do real time, we can batch deliver, and there's a lot of different ways it can be configured based on the needs of the FQHC. But that's the basics of how it works. We have this really sophisticated matching algorithm that compares these two sources of data so that we can route the data out appropriately to the FQHC that has subscribed to receive it.
Excellent. Thanks, Aaron. So now that we've got a little feel for what ENS actually is and how it functions, I wanted to touch on who is using this service, who are our subscribers. Currently, we have 65 subscribers to ENS, organized in a few different groups. We've got accountable care organizations, health plans, hospital systems, and provider groups, which include currently about 10 FQHCs. There's about 8 million lives covered by the service, and we deliver around 600,000 alerts per month. And since the inception of the ENS, we have sent out about 10 million alerts, and that was since 2015. I did mention that we have some FQHCs already subscribed to this service. Sherry, I wanted to ask you, why should FQHCs be interested in subscribing to ENS?
So we were fortunate, we are part of an ACO. So I was familiar with the ENS service and how it worked. So we saw the benefit in it right away as far as getting that information from the hospitals regarding our patients. Our patients were not really good at letting us know they had been at the ER, either admitted or just seen in the ER and gone home. And so the service helps us really focus on those folks who are going to the ER either a lot, frequent visits, and it also lets us know for all of the different hospitals that are around. So it's a great tool to help an FQHC manage their patients.
Excellent. So we've seen who's subscribing to the service and how ENS can benefit them, but Aaron, what kind of data are they receiving?
So that's a really good question. And it'll be interesting, Sherry, if you want to talk a little bit about this too. So we receive the data from the hospitals, as I mentioned, real time from the 215 connected data source hospitals. You have a image of that fun interactive map that's on the website. Definitely encourage people to go check that out and click around a little bit. So the hospitals are all sending us data in real time. And we're not actually manipulating or massaging or transforming the data. So we're sending the data across as it comes to us. And the data is based on ADT messages that the hospitals send to us. ADT stands for Admit, Discharge, Transfer. These messages already existed in the hospital systems well before we came along. They had an ADT system in place to track a patient's movement through the hospital. So you come in, you're admitted to the emergency department, you go to the cath lab, and then you're admitted as an inpatient, and then you're discharged. They already had a system in place to track patient movement through the hospital. And what we did was work with them to receive a copy of all these notifications. So the hospitals didn't have to create this data or this setup. They just had to copy us on what was already going on. And so we get these copies in real time, and they include some really useful information about the patient and their hospital encounter. So it's not a wealth of clinical data. It's not a discharge summary or a CCD. It's a pretty thin slice of information, but it's highly actionable. That's the value, is that you're finding out in real time the basics of a patient's hospital encounter. So the notification will tell you whether it's an inpatient or emergency department encounter, whether it's an admit or a discharge. Obviously, it'll tell you who the patient is, date of birth, address that they gave at hospital intake, a phone number that they gave at hospital intake, which we know is pretty valuable, right? In terms of being able to follow up with people, having a current phone number is really indispensable, right? You kind of need that. But in addition to basic demographic and contact information about the patient, You find out the event date and time, the event class, that's the inpatient or emergency, event type, whether it's an admit or a discharge, the patient's primary complaint. So this is the free text, stomach ache or headache, the complaint that they provide to the registrar when they get to the hospital. The diagnosis code, which is coded at or around the time of discharge, discharge disposition, which tells you where they went, whether they went to skilled nursing or to home or left against medical advice, or wherever they went when they left the hospital, the attending physician, and then other useful information. And just like we have the list of hospitals posted online, the list of kind of data elements that are available in an alert are also posted online. So a quick kind of caveat to some of this stuff, we can only route what we receive from the hospital. So diagnosis code, for example, if that's not coded by the hospital at the time of discharge or attending physician, if that's not included in the message that they send us, then we're not able to route it out. I'd also note that we don't standardize the data. So like discharge disposition, there's a lot of interest in standardization around that because not every health system uses the same code set. So those are things that we're looking at, but yeah, so it's really actionable, useful data. I want to be upfront about some of the limitations that we have, but yeah, everyone that has connected has been really pleased to have this window into their patient's hospital encounters. That's really what it is, an awareness of when your patients are seen at the hospital and the ability to work with them after their discharge. So Sherry, if I can put on Chris's hat for a minute here and ask a question, does that kind of reflect your experience in terms of the data that you're receiving and what you guys are doing with it?
So yes, once you learn how to read the algorithms, it gets a little easier when, because it's all time-stamped. One of the things I would mention too is that you do allow us to add in some fields of our own that we like from our system. And what we've done, because we have behavioral health, dental, and medical, is we've put a class in there so that we can track who, from which departments, I guess, really are our patients going to the hospital from. So is it a dental patient who went for a dental reason, or did they go for a medical reason? So we're trying to do that so that we can narrow down where we're benefiting the most from the information. So that's one thing we've added in. We added in also their primary care physician. It makes it easier when we're tracking and sending the information to case managers to take care of.
Nice. And yeah, just to elaborate on that for folks on the phone who maybe aren't connected yet, I'm really glad you brought that up. It's a great feature. So Treasure Coast is including information up front in the patient panel that they give us, and we're then routing that back to them as part of the notification. So they're not only getting the hospital data, but they're getting program information, PCP information that they included up front on their patient list. So that's a really great point. I'm glad you mentioned that and that you guys are getting good use out of that feature.
Absolutely, it's a great feature.
Aaron, I wanted to ask you something about, this is a common thing we hear about ENS. It can cut down on unnecessary emergency department and hospital utilization. Can you kind of go into how ENS can help with that?
Sure. That's one of the big goals that we're trying to facilitate, right? A patient goes to the hospital, and anytime really, when you transition from a higher intensity of care to a lower intensity of care, whether that's from the hospital to skilled nursing, hospital to home, skilled nursing to home, whatever the scenario is, there's always a danger that, maybe danger is the wrong word, but there's always a possibility that you may end up back in the hospital or back in skilled nursing, and that a more informed transition might have been able to prevent that, right? So we want to make sure that as a patient moves the setting of care as they ideally are going home, that they have everything that they need in order to avoid going back to the hospital. If it's necessary, then of course we want them back in the acute setting, but a lot of times it's not necessary, right? We know in Florida, there's been a bunch of studies on this. In Florida and nationwide, somewhere around half of emergency department utilization is potentially avoidable. So we want to do what we can to help reduce that. We know that CMS and commercial payers are moving from fee-for-service to value-based care, that there's a lot of interest in reducing readmissions, and that we think what we do fits pretty well in terms of offering people a tool to be able to prevent readmissions. So having an awareness that your patient was at the hospital in the first place is kind of key to that, and knowing when they're discharged so that you can reach out and follow up with them to make sure that clinical reconciliation and medication reconciliation have been performed, right? They went into the hospital with one set of prescriptions, may have been given new prescriptions at the hospital that may conflict or not line up with what they had previously. And a lot of patients need professional assistance to make sure that they're taking the right medications after they've been discharged. So being able to have that awareness, to do that follow-up, to get the patient into ideally a primary care setting after they've been discharged, to make sure, I mentioned medication reconciliation, to make sure they understand their discharge instructions. If someone has an issue with shortness of breath and goes to the emergency department and then is discharged, did they get an inhaler? Do they understand their instructions on how to use it? Do they have adequate supplies and family or assistance around them that can help them? And those things really, really help in terms of making sure that a patient has everything that they need to stay at home, to avoid an unnecessary hospital encounter. So that awareness and the ability to use that awareness to work with the patient to give them the resources they need, that's what we see as key. But I can talk all day about this stuff. We have Sherry here with us, so I'm going to again ask a question about your experience. Does that line up with, because you guys are actually using the data, does that kind of line up with what you're doing, and what else in addition to that do you have going on with this data?
So I agree with everything that you've said, and more. We found that it has really helped us focus on patients and help the patients understand when they should and shouldn't go to the ER, and when it would be better for them to call us or come see us. We like the timestamp in there. Really helps us to focus on, are they going on Friday nights? Are they going on Tuesdays at 6:30 and we close at 6? So it's allowing us to focus on, do we need someone on the phone at that time, or do we need an office that's open later? So it allows you to take a lot of information besides focusing on just that patient, but rather looking at how can we as their primary care provider make it easier for them to be seen with us and not go to the ER. And the case managers that we have working with the patients are RNs, so they're really able to speak to them. They will talk about medications they were given when they were at the hospital. They'll follow up with any discharge information that was given to the patient. And then they'll make an appointment for them to come in and then contact the hospital they were seen at to get their CCD sent over, so that the provider has that when the patient comes in. Because so many times if they just call us, say we were in the ER, they just bring the discharge sheet, which it really doesn't give the provider a lot of information to go on. So it's very helpful for the providers as well, because they come in and they have all of their documents with them.
Thanks for that insight, Sherry. Kind of on that note, I want to talk about how ENS can improve not only the experience for the provider, but also change the patient experience. Because a lot of time we focus on the benefits that the provider gets and the reduction in cost, but another really relevant point is how it impacts the patient experience. I want to share a little anecdote about a man who was admitted to a hospital with a heart attack. This man was prescribed warfarin as a blood thinner, and he was told to take it when he got home. What they didn't know is he was already taking Coumadin, a different blood thinner, which his provider had prescribed to him prior to the hospital visit. What he did not realize was that he was supposed to stop taking the Coumadin and only take warfarin, and instead he accidentally took both. So this gentleman ended up back in the hospital due to the combination of both medications. So as you can see, a very valuable function of ENS is to enable a patient's provider or hospital care manager to do an immediate medication reconciliation after their discharge. Not only this, but ENS can actually help personalize the patient experience. Imagine that if you were the patient, you've just been discharged from the hospital after some serious health issue. You might be confused, just like the gentleman in that story, as to what your next steps are, or maybe you have other things you need to attend to because you were in the hospital for a while. In either case, follow-up appointments there may not be scheduled. So ENS steps in by automatically notifying your provider or hospital case manager that you had been recently discharged, and this enables them to contact you right away and help schedule your follow-up appointments and answer any other questions that you may have regarding the treatment you received. So that's how it can really benefit the patient experience. To kind of shift gears a little bit, Aaron, I want to ask you, how does this data get from our data sources to the subscribers?
Sure. So I talked a little bit before about the process, how ENS works, right? We get data from hospitals, we match it to your list of patients, and then we send it to you. And that last part was left kind of vague. We send it to you. How do we send it to you? Based on your preferences. Well, there's quite a few ways to go ahead and configure this. So I want to just talk briefly about what the options are. We can do real-time or batch delivery. I mentioned before, most folks opt for a batch once or twice a day. It fits with their staffing and with their other processes, but we can do either one. Actually, we have a couple of subscribers we do both for. We do a real-time feed to one endpoint that they use for one need, and then we do a batch delivery once a day to another endpoint that they use for another need. So we can support either approach. And when I say real-time, we're talking within 15 minutes, and that's kind of a high estimate. So you have essentially in real time, within minutes of an admit or a discharge, when that ADT message is generated within the hospital's system, it's sent to us almost immediately. We match it to the panel, we route it to you. So it's essentially real time or batch. We can format it in a couple of different ways. These can be sent as the raw HL7 ADTs. So this is just standardized data structure. So it's just structured data that we could send to you. It makes it easier for importing it into systems that can handle HL7 data, like your EHR probably can handle that. Or we can send it as a CSV, so you can open it up in Excel and just work the data that way. And then we have a couple of different options for how we route the data out. We can send it via direct, and Chris mentioned earlier, direct is one of the services that's offered through the Florida HIE. We can set you up with a direct mailbox. Actually, we'd connect you with our partner who is Impriva, which is a direct vendor, and they have very affordable rates for mailboxes. Or if you already have a direct mailbox, which you as an FQHC very likely may already have one embedded and as part of your certified EHR technology. So if that is accredited through Direct Trust, then we would just test and make sure we can exchange, and you can use a direct mailbox you already have. Or like I said, we can work through Impriva to get you set up with one. A couple other options for receiving the data. We can do secure FTP sites. If you have a vendor that can set one up and just issue us credentials, we'll drop files there however often you'd like. Or we can set up a site and just issue you credentials, and you can likewise just pick up the files however often you like. A lot of subscribers opt for SFTP because they can set up their system on the subscriber side to automatically log in and pull any data that's there. So that's an option. And then also we have our Prompt web portal. Prompt stands for Proactive Management of Patient Transitions. And it's just a tool for interacting with the ENS data. So it's the same exact data that you get via regular ENS. It's just kind of a very lightweight care coordination tool where you and other members of your team can log in and interact with the data in different ways. So, and that's available. That's not an upsell. We're not trying to sell you something extra. That comes as part of a standard subscription, so it doesn't cost anything. And if you don't have those kind of tools, like it has a work queue, it lets you kind of flag notifications based on their status. You can enter notes in the new version that's going to be released this month. You can enter notes. You can build filters. You can do searches. So if you need that functionality and you don't already have it, we can set up prompt accounts for you. And these are not mutually exclusive options. So you can have batch delivery to direct or batch delivery to SFTP, real-time to direct, and the prompt account, or whatever combination of those you find useful. And of course, you can always change those down the road. There's no cost or anything. It just might take us a few days to update your subscription. So, and we already talked a little bit about what's in the alerts. That's not the whole alert that you're seeing there. Those are just kind of the data elements that people have indicated are of most interest. So we don't need to go into that table in much detail. But yeah, lots of options around how you get the data. And essentially when you were connecting, you would just tell us, hey, this is how I want my account set up. So those are the options. So Sherry, if I can ask, what did you guys opt for? I should have known this. I should have done some homework before the call. But what did you opt for? How are you guys receiving notifications at Treasure Coast?
We're doing ours through SFTP, and we do a morning batch.
Okay. Okay, great. Have we done we can take this offline, but have we done a prompt demo for you guys?
No, we didn't. No, I would say no.
Okay.
No, it doesn't ring a bell, so I would say no.
Okay. Well, let's take that up offline. Chris?
Yeah. Thanks for sharing your experience, Sherry. I want to ask you another question about, something we get a lot is how does an organization start to become a subscriber? Sherry, do you mind sharing your experience about how Treasure Coast became a subscriber?
So we originally worked with Diane Gladys, if I say her last name incorrectly, I apologize. But we did all of the paperwork as soon as the very first time that this was announced that it was going to be offered to FQHCs, and started testing with Audacious, with Aaron's company, and wrote our reporting in the system we use. We're a Greenway Intergy customer, and so we use their reporting system, Practice Analytics, and we wrote a report based on the requirements that were given to us by AI, Audacious Inquiry, and they were excellent to work with. Any issues, we tested, everything worked out well. We exchanged a few test files, and we haven't had, knock on wood, our biggest issue seems to be when we do something at our office and our firewall tries to block them again. But other than that, we've done really well with everything, and it was an easy setup, complete the paperwork, sign all the dotted lines, and we were good to go.
All right. Thanks, Sherry. Aaron, on that kind of subject, could you give us a little bit more detail about what the onboarding process entails?
Sure. It's simple. This is not a big technology process. I think Sherry used the word simple, so I'm gonna continue with that theme. Yeah, you don't have to build an interface. It's not a big lift technically. So first step is to sign an agreement. The standard agreement is like everything else that's posted on our website. And you can get a copy of it there and review it. This is often the part that takes the longest. And it's not a long agreement. It just, you have to do your due diligence in reviewing these kind of things. But so step one is the agreement. Step two is our onboarding checklist that is also posted online. That is a 5 or 6 page document. It gives you some background on how ENS works, and it's also the vehicle for you to communicate your subscriber preferences to us. So I mentioned before how often you want the data, in what format, and how you want it delivered by what means. Those are all, you communicate that to us through the onboarding checklist. You also tell us what date you're looking to start and your estimated panel size, who your main points of contact are. So it's really a document to fill in some details about your organization, so we know a little bit better how to set up your account. And that goes really quick. Again, that's only 5 or 6 pages. Step 3 is to set up a secure means for us to communicate. That'll be SFTP or direct. And that way you can send us your panel, which is step 4. You'll send us your list of patients. We'll review that and make sure that it's formatted properly and that everything lines up correctly, that we have adequate demographics to ensure a good match, right? Because we do need the data elements that are requested. Again, those drive the matching process. So we need good quality data coming into the system to ensure good quality matching, which is what we all want. So getting the panel from you is step 4, and then step 5 is go live. So if we had an agreement and an onboarding checklist and a clean panel in hand today, we could start routing notifications out by the 1st or 2nd week of September. So it takes about 2 or 3 weeks once we have a good panel where we can start routing those alerts out. And again, we would just set up based on your preferences the desired endpoint, whether it's SFTP, direct, and or prompt. And once we turn it live, you can log in and start pulling down those notifications. So we're very pleased at the diversity of subscribing organizations that we've worked with, that the simplicity of getting connected doesn't make this a huge technical lift. It doesn't impose a big burden on anyone, and we can start getting this really useful, really actionable data out in a pretty short time frame.
Awesome. Thanks for that, Aaron. So we've heard a little bit about the onboarding process. I wanted to note that there is some assistance available for FQHCs who would like to subscribe to ENS. Sherry, could you share your experience with that?
So as far as assistance goes with the, we're speaking about cost, and cost for the first year, I'm not absolutely sure of the dates. Right now is available to the FQHCs at no cost to us. The assistance, like I said, we had signed our organization up through Diane's community health organization. You would probably, I know Chris, she's been on with you. You probably know the name of that organization. I don't have it at my fingertips, but I do know there's 1 or 2 in the state that are helping with getting everything signed up and documentation for that.
Exactly. So what I want to touch on is this assistance we're referring to is funding that AHCA has, and it's limited funding, but it's available to help providers connect to ENS, and these are Medicaid providers specifically. The funding itself covers up to $5,000 a year per connection to become a data source. It also covers the cost of receiving data on up to 250,000 patients for a year, as Sherry mentioned. This funding is available on a first come, first served basis, and it's available through the end of the fiscal year, which is September 30th. So if this is something you might be interested in, it's important to go ahead and let us know. You can send any questions you have about onboarding to flhii@ahca.myflorida.com. And also at the end of this presentation, we'll have a slide that will have Aaron's email address and also my email address for any questions you may have. At that, Aaron, I'd like to ask you one more question. So we've heard a lot today about how ENS works, who's subscribing, how the data flows. but what can potential subscribers look forward to in the future?
That's a really good question. So just to step back and touch on the funding a little bit, and then we can talk about future ENS.
Sure.
So just want to stress the simplicity of the funding process. So we've had, I should have counted before the call, but I think we've had about 15 to 20 organizations that have utilized the funding available through AHCA to go live with ENS. And it's not that you're invoiced and then you have to send your documentation to AHCA and AHCA pays you and you pay out. It doesn't work that way at all. AHCA validates your eligibility and then they direct us as the vendor not to invoice you. So it really is that simple. No money goes through your hands to have to pay other bills. We just don't invoice you for those first 12 months. So, the future of ENS, and I think we'll have time for Q&A if anyone has questions about the funding piece. So the future of ENS. So that's a big question. We currently have about 8 million lives covered. So we've made really great progress. So we'll continue on that front to work with FQHCs, to work with provider groups and health systems that want to connect, that have consent to receive data on their patients. We'll continue to engage with them to get data out to them. So we'll continue on our current path. We're also very interested in adding additional sources of data. So we have acute care, and our presence in the acute care space is really great. We said 95% of acute care hospitals, but acute care is just one piece of the larger care continuum, and people are interested in particular, this being Florida, there's a lot of interest in post-acute, so skilled nursing and home health and hospice, in everything that potentially can come after an acute care encounter. And so we're working on that front to add new sources of data beyond just acute care. But we do have really great acute care coverage. I don't want to get too far in the weeds on what we have coming in the future. I don't want to overpromise, but we are looking for new sources of data. We also know that there is a lot of interest in a richer data set. So people very often ask about a discharge summary or even a whole CCD. And there are some things in the works on those fronts as well to make it easier for people to get that kind of information. But those are a little further on in the horizon. So I think that the future of ENS is just, to speak more generally, more robust exchange, richer data, but without the information overload that can sometimes accompany HIE. We want to have very targeted, very valuable, relevant data in real time that we're trying to get out to people. And so everything that we do going forward, I think, is going to build on that theme of just richer and better data to improve patient care.
Excellent. Thanks, Aaron. So at this point, I wanted to go ahead. It looks like we have a few minutes left to field some questions from whoever's listening out there. Like I said, you can either ask a question by raising your hand on the control panel, or you can type that into the chat box. I see one person with their hand raised, Brian Horvitz. I'm going to go ahead and unmute your line, so if you still want to ask your question, you'll have an opportunity to do so. Looks like you still need to enter your audio pin, Brian, so I can unmute your line here. Or you can type your question into the question box if you can. All right, looks like you put your hand down. So yeah, I don't think we have any questions at this time. Aaron or Sherry, was there anything else you'd like to add for today?
Sherry, the only thing I would add is to take advantage of the opportunity to do this and get the information for your patients. It's like a no-lose situation. So evaluate it, and then you can decide when it comes time that to start paying for the information.
Thanks, Sherry. Well, I appreciate you joining us today. It was really nice having your insight on how FQHCs can benefit from ENS. Aaron, did you have any closing remarks as well?
Yeah, just real briefly. Thank you, Sherry, for joining the call this morning, and thank you, Chris, for hosting this. I think this has been really useful. I hope the folks on the phone learned a little bit about what we're trying to do here. And yeah, we're all very accessible. So give Chris or myself a call or shoot us an email. We're happy to talk with you about this stuff. We're just excited to be part of this and to be able to help get data out to physicians who can use it to improve patient care, right? We all, Chris and Sherry and I all live in Florida, so this is not just work for us, but it's also a meaningful thing for our families and friends as well. So just excited to be part of this and excited to continue to talk to folks about it. Like I said, just reach out. I'm happy to discuss further.
Awesome. Thank you, Aaron. And to everybody out there listening and watching, thanks for joining us today. As I said previously, all the slides for the PowerPoint will be sent out via email, as well as a link so that you can watch the recording if you feel like you missed anything. On that note, have a great afternoon, everyone, and hope to talk to you soon.
Yep, thank you.